So welcome to the September Grand Rounds 2022. I'm going to ask that everybody make sure you're on mute unless you're specifically asking a question. And make sure that you either scan the QR code or sign in with the code that's on the screen right now so that you can get credit for the live presentation. The code does expire. If you're watching the recorded version, the code has already expired. So in that case, you're already on the right site anyway, and it'll get taken care of for the recorded version. Today we have Dr. Jeff Bays talking to us about mechanical diagnosis and treatment for diagnosis and therapy for the extremities. Dr. Bays received his Bachelor of Arts in Exercise Science from Keene University, his Master of Science in Physical Therapy from Marymount University, and his Doctor of Physical Therapy from Arcadia University. He's board certified in orthopedic physical therapy and received a certification in mechanical diagnosis and therapy from the McKenzie Institute. Dr. Bays focuses on the diagnosis and treatment of orthopedic and spine disorders and emphasizes a hands-on and active patient-centered approach to treatment. He's served as adjunct faculty at Arcadia University in the DPT program and is currently the Associate Director of the St. Luke's University Health Network Orthopedic Physical Therapy Residency Program. So without further ado, I will turn it over to Dr. Bays.
Thank you, Steve. So today's lecture, we're going to dive into mechanical diagnosis and therapy for the extremities. It is an approach that some of you, if not all of you on here, probably are not familiar with. But this is the activity description, the statement of need, and the target audience is all providers. This is the designation statement, and I have no financial disclosures. So today we're going to discuss, again, Extremity MDT. We're going to do a little bit of background on extremity pain of spinal source. I'm really going to breeze through that very quickly because we're going to assume that the patients that we are dealing with, we have ruled out the spine. We're going to talk a little bit about the background of Extremity MDT. We're going to review MDT extremity classifications, extremity assessment and classification, management of the specific MDT syndromes, and I have two case presentations that we will present, that I will present. And again, this is not meant to make everybody proficient in trying to examine somebody from an MDT standpoint when it comes to the extremities, but I really want to try and get people's thought process to change in a different direction than what we are accustomed to, because there is good evidence out there that it is effective. So let's start by talking about, exactly what mechanical diagnosis and therapy is. It was, again, developed by Robin McKenzie. Begins with a clinician taking a very detailed history. More often than not, 80% of the time, you'll be able to identify the appropriate diagnosis and treatment after you take that detailed history. You're going to utilize a structured sequence of repeated or sustained end range loading to assess a mechanical response in that particular patient. The process promotes patient empowerment, increases satisfaction with treatment, and is cost effective. I was just recently at the advanced extremity course in June, and the instructor was Scott Herbawi, and he was speaking from a cost effective standpoint, and more so as it relates to the spine. But just before the pandemic hit, China was outsourcing. They were getting ready to pay. They've realized they had a problem with low back pain and were looking at a cost-effective way to treat it. And they were going to send MDT clinicians over to train thousands of therapists, and simply because, being socialized medicine, China was really trying to keep their costs down and utilizing what was, they felt in their minds, most effective, and we're going to utilize that approach. However, the pandemic hit and the trip was canceled. So my thought is they are still having a low back pain problem, which we all are having. So I'm a big quote guy, so I really like quotes, and these are just a few from Rob McKenzie, who's pictured there. My patients taught me all I know. Really, the patient is, I try and tell clinicians, residents, whomever I'm interacting with, the patient is going to tell you, if you allow them, what is wrong with them. In 1990, this came out of his cervical textbook. If patients are selected and treated as outlined without dilution or contamination of the principles, the procedures will be as effective 50 years from now as they are today. And then the last quote there, I had to paraphrase it because it's in his original lumbar text, which I found fascinating, which was in 1980. And it was presented at both when I just recently took the advanced extremity and when I took the retook part Scie, which includes the extremity courses now. I believe the principles laid out for the spine can be utilized in the peripheral joints as well. And that was in 1980. And as we'll talk about later, we'll talk a little bit about the background of MDT and how it has evolved. So the XBOS study, which is a extremity pain of spinal source, this is really, if you are going to do your due diligence, you really need to clear the spine before you think about examining the extremities. And in this study, and again, it was MDT clinicians, 369 patients with isolated extremity pain. Again, these are just the highlights. 43.5% of the patients with isolated extremity pain had a spinal source of symptoms. Further looking at it, when the pain was located between the joints, so in the thigh and the lower leg, so you're looking at in between the hip and the knee, and in between the knee and the ankle, 72% of those patients, the symptoms were coming from the spine. And similar in the upper extremity, even higher incidence in the upper arm and in the forearm, if they were in between the joints, 83% were from spinal source. So we really need to do our due diligence with clearing the spine. And the joints with the greatest proportion of spinal source were the hip at 71% and the shoulder at 47%. If you want further highlights on the XBOS study, I would suggest you go to the Grand Rounds presentation done by Katie Wilkins, Dr. Katie Wilkins. At the time, she was Dr. Katie Terry. So when you look on our homepage, go to the continuing ed portion and the Grand Rounds archives, and she did an excellent presentation on the XBOS study. Taking from that, there was a new paper that just came out in June of 2022, exploring the indicators of extremity pain of spinal source as identified by MDT. And what they did was they took the XBOS study and tried to identify what factors would lead you to, what indicators would lead you to believe that you needed to do a further spinal assessment. So these 5 indicators were found: presence of paresthesias, effect on symptoms with sitting, neck or trunk flexion or cervical rotation, postural change affects symptoms, restriction of spinal movement, and no restriction of extremity pain. So when they looked at this, they tried to identify, okay, now if I have those factors, where do I go from there? We need to explore the spine a little bit further. So if no indicators are present, your screening can be minimal. And generally speaking, we'll do a range of motion screen. Let's take the neck, for instance. We're looking at all movements of the neck and really making sure we're trying to get that patient to the end of the available range to see if it suggests reproduction of their symptoms. Any number of indicators present. So to do a more extensive screening, and this was always my confusion is, okay, we screen the spine, but if I don't screen it thoroughly enough, am I really going to rule it out? So with these indicators, it gives you a better idea of when you should explore the spine even further. So explore repeated end range movements with the patient and clinician overpressure in the sagittal plane. And this most commonly in the lumbar spine is extension and lying, and in the cervical spine, retraction with extension with overpressure. Or you can also do sustained extension in the lumbar spine. If no effect on the extremity baselines, which we'll talk about a little bit later, if you have no effect on the extremity baselines, but you have 2 or more indicators that we just mentioned, consider exploring lateral procedures in the cervical or lumbar spine. So in the lumbar spine, we could talk about side glide, and in the cervical spine, it could be lateral flexion or cervical rotation. From a repeated movement standpoint. If you have a change in the extremity baselines, you will use what we will term the traffic light guide, which we will talk about more in detail further in the presentation. Continuing on that, these are the metrics that were found in that study, so the rationale for exploration of spine, and the optimal number of indicators for the classification was 2. This gave you the best balance to rule in and rule out the spinal source, and you can see the metrics there. This gives you an algorithm of the spinal extremity exam. If you establish the patient baselines, screen the spine. If you do not have you retest the extremity baselines, no effect on the extremity baselines when you screen the spine, you go into your full extremity examination. If you have an effect, do your full spinal exam, provisionally classify the patient, and treat the spine. If they're progressing well, continue to treat the spine. If they're not progressing well, you may need to then incorporate a full extremity examination if you've exhausted your spinal examination. So from an Extremity MDT background, the initial course was taught in 2001, and it was called Part E. This has evolved over time. I took Part E in 2004, and I honestly will tell you, when I took it in 2004, I was not buying it. I was buying the spine MDT full tilt. But when I took the extremity, because the one thing I remember from that course was I remember watching a video of Robin McKenzie treating a shoulder patient, and it was the diagnosis coming in was a frozen shoulder. And literally the lady had probably, I'm going to say 90 to 100 degrees of shoulder elevation in both flexion and abduction. And he starts doing repeated movements with functional internal rotation, so reaching behind her back. And, he's doing the old go further, further, further. And then he retested her shoulder flexion, and her shoulder flexion went from 90 to 100 degrees to approximately literally 150 degrees. And I'm like, you don't see frozen shoulders respond that way. And the one comment he made, the lady had been dealing with this problem for 5 years. And I remember the one comment he made was, well, in the United States, you would have had surgery 5 times already for this current problem. And he literally got her range of motion to go from improved by 50 to 60 degrees just by doing repeat. And I could not see how that was affecting her ability to move But when I look back on it now, she was a shoulder derangement, which we'll talk about. So now what has occurred with Extremity MDT is you have part C, which used to be advanced lumbar. Now they've incorporated its advanced lumbar and the lower extremity. And part D is, which used to be cervical, advanced cervical and thoracic. They've now included the upper extremity in that. And now the part E course is the advanced extremities course. And you now have to take the advanced extremity course going forward to sit for the credentialing exam. So that's just a little bit of background. Some of the other background, they utilize a similar classification system with derangement, dysfunction, posture, and other. And the biggest variation, obviously, is if you're not familiar with it, but if you are, the biggest variation is dysfunction, which is broken into two categories, which is articular dysfunction and contractile dysfunction, which we'll talk at length shortly. So again, as we look at how the Extremity MDT has evolved, in a survey in 2006 of MDT clinicians, they surveyed these clinicians and looked at 753 patients and basically wanted to know what percentage of derangement, articular dysfunction, contractile dysfunction, and other they were coming up with. And you can see the statistics there. They redid the survey in 2012. This time it was 30 MDT clinicians, 388 patients. What you see is as people are utilizing the system, I think, more effectively, they're finding there was an 18% increase in derangement, 16% decrease in articular dysfunction, a 10% decrease in contractile dysfunction, and an 8% increase in other. I think the other thing to identify here is in the 2006 survey, 72% of the patients were able to be classified. In the 2012 survey, 100% were able to be classified, even if they were put in that other category. And I think just as we know about the treatment-based classification approaches and classification through this system, that will should help guide your treatment and a more effective and efficient way to treat that patient. So it really is a good idea to try and classify these patients as long as you're classifying them appropriately. When they looked at the prevalence of each particular joint, look at the lower extremity prevalence, hip derangement was 31%, knee derangement was 43%. I don't want to bore you with all the statistics, but you can see that ankle derangement was probably the lowest, I think at 22%, shoulder derangement 42%, and elbow derangement 40%. You can already tell where I'm going. Derangement is going to be your biggest classification, with the exception of probably the elbow, which is equally derangement and contractile dysfunction, and the ankle, where contractile dysfunction is a bit higher than derangement. So reliability of classification, you look at all these studies and they were vignettes given to MDT clinicians, and the reliability, it showed good, acceptable reliability. They did a systematic review in 2017, showed strong evidence of reliability when vignettes were used. There was limited evidence of acceptable reliability when real patients were assessed concurrently by MDT clinicians. So I think obviously going forward, there needs to be more of that. If we're going to classify these patients, we have to have improved reliability, especially when one MDT clinician to another MDT clinician is occurring. Review of the MDT classification. So again, we have derangement, dysfunction is broken into articular and contractile, as I stated before, postural, and other. We're going to review each one individually. Derangement, it's a clinical presentation which demonstrates directional preference. So again, when you look at the spine, we look at directional preference in the spine. The thing is with Mackenzie, and you'll see what the extremity is, McKenzie MDT is extension. Well, you're going to see there's a lot of extension being done in the extremities as well. It's a directional preference in response to loading strategies and is typically associated with a movement loss. You'll see if they don't have movement loss and they're having pain complaints, we may start to classify them into that contractile dysfunction category. Key clinical features in derangement: pain distribution, typically going to be local or referred. It's not going to be radicular. The stage could be acute, subacute, or chronic. The status of it, this is another thing. Improving, it's getting worse, it's unchanged, it's not very consistent, it's kind of all over the place. The pain can be constant or intermittent. It's another big sign you'll see between derangement and dysfunction. Movement loss, yes, there's always a movement loss. Pain during or at the end range of movement. So that's another key principle. Pain during the movement, or they have pain just at the end of the motion. Is there a directional preference? Absolutely. Other key clinical features: centralization. There's no centralization in the extremity. One of the things they presented on at the course that I went to was you may get a localization of the symptoms, but you won't get what's commonly termed in the spine as that centralization. Deformities, there's no deformities. What I will say though, and I saw this at part C, you may see if you are, from a repeated movement standpoint, if you're going in the wrong direction, you may see the person progressively lose motion. And I saw that right in front of my eyes with actually a participant in the course who was having shoulder pain. The more he did one particular motion, the more he lost his ability to flex. And then obviously the more he did another motion, he started to regain that motion too. So not so much a deformity, but a progressive loss of motion in that particular instance. Hallmark signs of derangement: variability and rapid change. These are the patients, and you'll see it in the case scenarios that I have to present. You will see a rapid change in either their motion or their symptom response, or hopefully both. And again, that variability, sometimes they're good, sometimes they're bad, symptoms are worse, it's not consistent. Response to resistive tests may have neural inhibition. So in the extremity, you can use this as a baseline. Neural inhibition, in the course, they gave specifics for each joint. So for instance, the hip, they found that more neural inhibition was in hip abduction. In the knee, it was quads greater than hamstrings. In the ankle, it was, you get this neural inhibition or weakness in dorsiflexion. Shoulder, it was external rotation. I had a prime example of a patient recently who responded to repeated shoulder extension. He initially was concerned he had a rotator cuff tear, and as was I. He had pretty significant external rotation weakness, and literally his eyeballs got really wide after we did repeated shoulder extension with his shoulder internally rotated, and when I went back and retested his external rotation, it was significantly stronger. His range of motion improved, but when he saw that his external rotation, he was an engineer, so he's really hyper-focused, and he had a good sense of his body, and when he saw that, he was really, really taken back by, well, we just did this, and that engineering brain took over. We did this, and it made me stronger. How did that happen? I'm not sure I had a good explanation, but we talked about neural inhibition and reducing his pain, and therefore his muscles were working more, his external rotators were working more effectively. Do they have a previous history, or is this, again, in the spine, this episodic nature of these symptoms, that anterior knee pain patient that comes in that really is up and down depending on what they do, does that have an effect on, especially when you're taking that history, you should start to build on what you're hearing that patient say. And the derangement's considered intra-articular, as we'll talk about from our dysfunction standpoint. These are considered intra-articular. When we look at dysfunction, we're looking at articular dysfunction and contractile dysfunction. So the articular dysfunction is considered periarticular. It's a clinical presentation where symptoms are produced consistently and only at a limited end range. Contractile, the clinical presentation is symptoms are produced with sufficient loading of the musculotendinous unit. This is the one that's most difficult to differentiate from derangement when you're dealing with the extremities. Articular and contractile dysfunctions, they differ regarding time frames and loading requirements for remodeling. Again, when you think about a periarticular structure that's tight, we're trying to remodel it. We got to stress it at the end of the range. Whereas a contractile dysfunction, we're trying to load it maybe through the range, which we'll talk about a little bit further. I'm going to go through some key differences that we'll find between articular and contractile dysfunctions. Again, this goes into helping your decision-making process if you're on the fence, whether it's articular dysfunction, contractile dysfunction, or if it's derangement, or if it's other. So symptom location, usually locally referred for articular dysfunction. In the course they presented, I think some people will disagree with this. I sometimes might disagree with this if we're dealing with a musculotendinous unit, but they said the symptoms will be very local, like the size of a $50. I think the trigger point people would not necessarily agree with that, but that's the information they presented. And you know, again, let the patient tell you and utilize that information appropriately. The state of the problem is always chronic. The contractile dysfunction may present acutely because they've had an acute flare-up. Pain is usually is always intermittent. With contractile, again, may not be after an acute flare-up, but typically the contractile is going to be intermittent. Articular dysfunction is always intermittent. It's you produce the pain and then it goes away. Status of the pain, and it is unchanging. Time frame for development. This is another thing that you could put together. It's pretty predictable for articular dysfunction, 8 to 12 weeks. And in contractile dysfunction, it may be a little bit shorter, but again, it's not going to be that acutely brought on patient. Response to loading, slow and predictable. It'll remodel over weeks for articular dysfunction. And for contractile, it may respond quickly within 4 to 6 weeks, but then some respond more slowly depending on the loading strategies you're giving for that tissue. Response to overloading, articular dysfunction really is difficult to overload and make worse. If you've made them worse, either of these, if you make them worse and they remain worse, then what you're probably dealing with is an underlying derangement. Response to resisted tests, articular dysfunction, no effect. It's not stressing the dysfunctional tissue, so you should have no effect. Contractile dysfunction will produce the pain. So again, there's a big difference between the two. Response to passive movement. Here's another difference. With the articular dysfunction, you will produce end range pain in the direction of the restriction. With contractile, there should be no effect. They may report an end range stretch. But again, from a contractile, you're not contracting the tissue, so you typically should get no effect. Response to active tests. Produce end range pain, no worse. That's the key. If you produce the end range pain, no worse after. Can produce it for contractile, you can produce during movement or at the end of the range, and again, make no worse. I'm going to go down to movement loss. Loss of end range movement, always an articular dysfunction. Contractile dysfunction, again, there's the big one, full range of movement. Their joints should be full. Postural syndrome, again, clinical presentation arising where symptoms are produced from prolonged static loading. This is rarely seen. I haven't seen it. I'm sure my colleagues that I work with who practice this quite a bit have not seen it in the extremity. I've seen it in the spine. But again, really, you change the position, symptoms go away. The other subclassification of the classification of other, so again, you've determined that it's not derangement, it's not articular or contractile dysfunction, it's not postural. You put them in this other category. Here are some examples of other, obviously serious pathology. We have to rule out the serious pathology in our exam. We are good at that. We should be able to do that, and we miss Very, very little. Chronic pain syndromes, inflammatory arthropathies like RA, if that's their primary issue, mechanically inconclusive. You know, some patients, you just move them around and you move them and you move them and you move them and you can't make a conclusive diagnosis from a mechanical standpoint. Peripheral nerve entrapments, post-op. Post-op's what I will tell you as it relates both to the spine and the extremities. If the person is not making satisfactory progress as they should, based on healing times, based on their protocol, and based on what you're allowed to do as a result, you may want to explore a mechanical exam to see if they have an underlying derangement post-operatively. But again, must be cleared, must be able to do it, that full type of exam. Soft tissue disease process. These are classified. Frozen shoulder is under this. Plantar fasciitis is under this. Dupuytren's is under this. Frozen shoulder is not listed as an articular dysfunction. It is listed as a soft tissue disease process. Trauma is another one. And again, if somebody's from a trauma standpoint, they have a delayed process, it's not going according to what your expectation is, then you may want to do a full mechanical evaluation on them. Structurally compromised, these are the patients with late stage OA. They've had an ACL rupture, an irreducible meniscal tear, things of that nature. And vascular is compartment syndrome, as an example. So extremity assessment and classification. So the history, it is a very systematic approach. You know, in all the every McKenzie MDT course you go to, there is a very systematic sheet that goes along, and you typically will follow that status. You know, we need to get the information out of the patient. What makes them worse? What makes them better? Do they have a history of back pain? If the person comes in for hip pain or knee pain, and you may get the response, well, why are you asking me about my back? That's one of the indicators. If they have that history of back pain, then you may want to start to lean towards, okay, let's make sure it's not coming from your back. And at the end of your exam, you should be able to have a provisional classification, in my opinion. You should be able to determine if it's derangement, if it's dysfunction, and then prove yourself in the exam. Physical exam, you're going to get your baselines: pain, functional activity, whether it be a squat or a position that they need to get into for whatever it is they want to do, or the mechanics of the joint. A lot of times you'll hear a patient say, the joint just doesn't move freely enough. It doesn't feel like it feels stiff, doesn't feel like the other one. You're pushing on it at the end of the range and it's painful, or it just doesn't go as far as the other one. Movement loss, both active and passive, you're going to look at. Resisted tests, repeated movements, and static positioning if you need to. From a repeated movement standpoint, so we're not, again, it's not the intent of this Grand Rounds presentation to go through every joint and how you're going to do the repeated movements exam. But as we go further, you'll see I'm going to give you the prevalence of what movements tend to be more beneficial than others. But in a general sense, you can start unloaded, especially with the lower extremity. The knee, for example, you can start with unloaded knee extension, or you can then add loading, going from semi-loaded to loaded. Now, the pictures that are there are just pictures to give you an example. The picture on the left, with the gentleman with his foot propped up on the stool, that's unloaded knee extension. He's doing active knee extension. You know, it's basically a quad set, and he's adding self overpressure into extension. The one where he's sitting, that's considered semi-loaded. And then if you went fully loaded, because you wanted to add more load because you're not getting the response, or he's plateaued, you would do that in standing. And again, it's active knee extension with patient-generated overpressure. You don't have to do that unless it is the patient-generated overpressure, unless it's warranted. You may need to add a lateral component. Again, you're always reassessing your baselines. Sometimes they will plateau, or you're not getting the response, you may need to add a lateral component. And with the knee, we'll talk about it in a few minutes, but you can do internal or external rotation of the tibia. This is the extremity algorithm. Again, if you've confirmed that it's an extremity source, you've already excluded the spine, you do your repeated movements exam. If their symptoms are improved or the mechanics are better, it's derangement. If not, inconclusive, repeated movements produce only end range pain and no worse, yes. Articular dysfunction, no. Then you need to do your resistive tests. If that produced no worse, you may be more inclined to diagnose them with contractile dysfunction. If not, repeated movements exam and resisted tests are no effect. Pain only with sustained posture, postural syndrome, and then if not, then we're in the other category. So when you're examining a patient and when you're treating a patient, we like to use the traffic light guide. Red light, if you get a red light, that means the symptoms are increasing and they are remaining worse. If this is occurring, it is what it is. You stop what you're doing. Again, and we should be doing it not only with the McKenzie system, we should be doing this with any system we're using with the patient. It seems obvious, but sometimes I hear patients all the time. When I left, I was at this other clinic. Every time I left, I was worse than when I showed up. That should not happen. Amber or yellow light, symptoms are provoked, but they're not changed. So you increase or produce the pain, but it's no effect. This gives you the idea that you can keep going, but proceed with caution, just like the yellow light says. And that's what I tell the patients. Proceed, but proceed with caution. Add a little more force, add more reps, make sure you're getting to end range. All these force alternatives we'll talk about. Green, this is the patient that is really happy. Their symptoms are improving or they've abolished and they are better as a result. Keep going with what you're doing. There's no really need to add anything unless they plateau. Management of the derangement. You need to explain to the patient what the nature and the cause of the problem is, just so they understand. There's no pathoanatomical cause, and this is my biggest problem with trying to explain what is happening with a derangement in the extremities. You know, some of the things that I use are, well, something is obstructing the joint's ability to move. Well, what is it? Well, I really don't know because I can't see in there, but all I know is when we did this other movement, your ability to move that joint started to improve. Performance of end range reductive movements regularly without lasting symptoms. Again, you're getting that green light versus that yellow light. Aggravating positions should be avoided initially. You have to tell them it's not going to be permanent. You don't have to avoid those. We're going to get back to those movements, but it's not forever. 10 to 15 reps every couple hours, as long as the reductive movement continues to be making them better. Reassess in a few days, use the traffic light guide, self-treat. This is the big thing. The patient we're giving the patient the ability to treat themselves and maintain that improvement. The big thing with the joints is the more planes of movement, it's like the neck and the low back are different because you have more planes of movement. The more available to that joint, the greater the variability may be in the reductive directions. I can't go without mentioning the 4 stages of management. You need to reduce the derangement. This means the symptoms and the mechanics are improving. Use your force progression. Maintenance of the reduction. Once the reduction is reduced, we need to make sure it consistently remains improved. Recovery, you know, we start to go in the opposite direction. Do they re-derange? Just as that patient I was telling you about that was at the course, the more he started to flex his shoulder, the less movement he got. The more he started to extend, the better he got. So eventually we want them to be able to flex that shoulder repeatedly without losing that motion. And that's where we go into recovery of function. And then the prevention of the recurrence. You know, in the spine, I don't use this as much as I should probably in the extremities as I do in the spine. And do that reductive movement once or twice a day. You know, in the spine, I'm continually telling patients in the spine, I'm having them do their reductive movement once in the morning and once at night, just as they, as the rest of their lives, because there's a good chance it's going to recur. I don't do that as much with the extremity, but not to suggest that's not a good idea. These are the preferences that I was talking about earlier. So in the lower extremity, the directional preference, when they went back and looked at that May study survey in 2012, 55% of the patients responded to in the hip responded to extension. 77% in the knee responded to extension. 53% responded to dorsiflexion in the ankle. In the upper extremity shoulder, 38% responded to extension, 31 internal rotation. The case I'll present is going to put that one in upside down. Elbow, 76% responded to extension, and in the wrist, 48% responded to extension. So again, if you're going to test movements, this kind of gives you a good starting point. You should always base it on what the patient's telling you. But again, these are more of the preferences that these patients had in this particular study. Oops. So again, in the management of derangement, you have your force progressions, patient overpressure, clinician overpressure, mobilization, force combinations. That's what the picture is showing. You may need a combination of the forces, change direction, extension to external rotation. Back to the force combination, you can see in sitting, the patient's doing knee extension with his tibia internally rotated. Again, that's just trying to combine knee extension with internal rotation. Then in standing, he's doing it with an externally rotated tibia. And force alternatives, you can change the loading, you can do more static. That's a force alternative. You can do ballistic. At the course, I can't imagine doing this with a patient, but one of the elbow derangements that they had him doing ballistic elbow extension, which I guess in the elbow it's okay. I'm not sure I'd want to do that too often, but he had to do that with that patient to get the response he wanted. The 4 sins of unsuccessful management, keep these in mind. Not getting to end range. End range, the saying is end range is where the magic happens. Get that patient to end range. And again, it really doesn't matter what system you're using. Please try and get the patient to end range to see what is going to happen from a symptomatic and a mechanical response. If we're not getting to end range, we live in mid-range all day. If we're not getting that patient to end range, we may not know how that joint is going to respond. Not utilizing sustained enough, not enough reps. We change direction too quickly. This happens to me in the spine frequently, and I think will happen the more I use the extremity system. I want to go lateral too quickly, and sometimes I just haven't done some of these other things of getting in the end range, using sustained or doing more reps before I have to go in a lateral direction. Management of articular dysfunction, we need to remodel the involved structure. Okay, so again, repeated movements that produce the pain at the end of the range. It has to be sufficient enough to produce the patient's pain. You have to give the explanation of the nature of the pain. Patients aren't going to want to put themselves in pain. You have to give them the reason behind why they are doing it. How is it going to help them? Well, I'm not going to put myself in pain all the time. But again, the key is if you're putting them in pain while they're moving and they're not worse as a result, that is the key. If they are worse as a result, then you probably have a derangement. So again, it should be produce, no worse. And it should be a fair amount of discomfort. 4 to 6 is what is recommended. Set the expectation of the length of recovery. These do not get better quickly. Let that patient know that. They can't. If they get better quickly, it was a derangement that we missed. But if if it is an articular dysfunction, the remodeling that tissue is going to take longer than a couple days. Make sure they know the expected return, their expected recovery. It helps with patient satisfaction. If they don't know that, their expectation is not going to be set the correct way. Contractile dysfunction. So the movement that causes the greatest amount of pain also provides the greatest amount of stimulus. Okay, we have to consistently provoke the patient's pain with controlled loading, 3 to 5, and again, produce no worse. The pain must abate once the load is removed. You need to do this to remodel the contractile dysfunction. Utilizing that target zone, where in the range is the pain provoked? The program should be continually modified based on what that patient needs to get back to doing and their symptomatic response. You can blow these people up very quickly, so just be careful. The dosage, it's individual, dependent on the assessment and the response, okay? Many different protocols in the literature, which I have on the next slide. Other consideration, individual capabilities, their access to equipment. Some of these you don't need a lot of equipment. Change in frequency depending on the load, okay? The more load, you may not want to do it, or the more higher level the activity, you may not want to do it as frequently. Change one activity at a time. If we give them too many activities and they blow up, we're not going to know what the activity is that made them significantly worse. These are some protocols in the literature that you have. Again, isometric versus eccentric, heavy, slow resistance, all have their place. I put this in here. These are 10 things we should not do to tendons based on Jill Cook's work, and she presented this in 2018. Rest completely. We don't want to rest the tendon completely. Passive treatments, and I emphasize that. This is a contractile tissue. We don't want to really do passive treatments with any of these patients. But this is something that we shouldn't be doing with this particular population. Injections. Injections have not shown to be overall effective. Don't ignore the pain. If the load is too much and the pain is too high, you run the risk of blowing that patient up, making them significantly worse. Stretching. Stretching adds a compressive load that could be detrimental to the tendon. Massage may increase the irritability of the tendon. So if it's a contractile dysfunction and that's what you labeled them, put away the Graston tools and such and start loading the tendon. That's not going to load the tendon sufficiently enough to get the tissue to remodel. Images. We know that that's not going to give us what we need to know. And what the image looks like is not going. Pathological tendons can tolerate a lot of load. Be worried about rupture. Again, pain is protective. That will protect them. Most people that rupture don't realize they had a problem. And you think about that person that ruptured their quad tendon. Well, it was probably something that happened as a traumatic event. Don't take shortcuts in rehab. It's not going to be pleasant. The patient has to identify or be able to tolerate that pain that you're going to put them in, but they have to understand that. Misunderstand what loads are high for your tendon. So again, I'm not going to go into how to manage posture. That's easy. I'm not going to go into how to manage the other syndromes, but please try, when you're examining that patient, please try and classify them appropriately, however you want to classify them, because I think that will help with your treatment. Case scenario number 1. This is a 17-year-old patient, came to me, left knee pain 2 weeks prior after a softball tournament. She is a softball catcher. She came in with left anterior lateral knee pain with squatting and catching position. And you'll see the catching position in the next slide. It was as close as I could get, but it's pretty close. Her pain has gotten better. It's now intermittent, but limits participation in softball. She has a tournament in 1 week and potentially will be playing 7 games. Aggravating factors: squatting, kneeling, stair descent, knee extension, and that catching position. Rest and ice makes it feel better. No history of back pain. The pain is isolated in the knee joint. No paresthesia. So again, identifying those key clinical indicators that it may not be warranted to do a pretty in-depth lumbar screen. So her baseline's painful squat, and she could not get into a position similar to that. That left knee was in that position. Lumbar spine, she had no range of motion loss. That is as far as I went. She had mild loss of knee flexion. Her right knee was active, and she had pain during the movement. Mild loss of knee flexion, passive range of motion. And she did have knee pain. She had full knee active extension, but she did have pain with knee extension and eye overpressed. Resisted testing was no pain within functional limits. Repeated movements. I did unloaded knee extension first. We did, I would say, probably 30 reps and retested her squat. That was what I looked at first, and it was no change. We did semi-loaded. So the picture you saw with semi-loaded, the person sitting down, going into active knee extension with patient overpressure. She did it, produced her pain, didn't make her worse. I retested her squat. She got further down into her squat. I had her do it again, more reps. Symptoms were abolished when she was doing it, and then she abolished her symptoms with the squat and the catching position. So she was able to get into that position without no pain. So there was that very drastic change in her functional movement and her baselines. The pain was abolished. I went back and retested her ability, her knee extension with clinician overpressure, and it was still painful, but the other things were not. I gave her a home exercise program, semi-loaded knee extension every 2 hours. It allowed participation. I allowed her to participate in her tournament if she remained improved, and she swore to me that she would do these in between each inning, and she did. She followed up 1 week with me, complete resolution of her symptoms, return to softball without restriction. Her squat was full, her catching position was full. She was able to participate in the tournament. Again, I don't have a pathoanatomical explanation for this, with the exception of I stressed her joint enough in one direction, it made her ability in the other direction improved, and she was able to do her functional tasks. I'm not sure, was her joint not moving correctly? The analogy I use is the mulligan with mobilization with movement. That joint just maybe was off kilter a little bit and not moving correctly. That's a technical term, off kilter. But again, just not moving the right way. And we started loading it in one fashion, and it helped in moving in the opposite direction for this case. The next case is a little bit different. This is a 27-year-old male, 2-month duration of right anterior shoulder pain. Pain was intermittent and local. Reports some good days and some bad days. Can't work out. Shoulder flexion was aggravating, reaching, playing tennis. Easing factors were inactivity. No history of neck pain, no reported paresthesias. Past medical history, unremarkable. C-spine was clear. Right shoulder flexion, moderate loss and pain at the end of the range. Shoulder internal rotation, moderate loss with pain during movement. Right shoulder external rotation, weakness. So I started doing repeated movements with it. I have it in my mind he's a derangement. Extension made him worse. And again, I utilized, based on what he told me made him worse, flexion, I went extension. I went to functional internal rotation. That made him worse. Like, now what do? I'm not going to go into his movement into his loss of movement. And now I'm curious why I didn't do, the next movement would be horizontal adduction. I didn't go there for some reason. Maybe it's because I hadn't taken the course yet. I went into repeated shoulder flexion. And lo and behold, as I'm doing repeated shoulder flexion, his symptoms start to improve. He gets better. His baseline started to improve. His internal rotation improved. I gave him his home exercise program was repeated flexion with patient overpressure. Return 1 week later, all baselines were improved but not abolished. I added clinician overpressure, so I was adding overpressure, gave it to him against the wall to do it. He completely abolished. 2 weeks later, he returned, full recovery, back to what he was doing. I added no strengthening to the gentleman. This is what I gave him. He didn't need me anymore. Off he went. He was fully recovered, back to working out, back to playing tennis. So again, got curious, went in a direction that maybe wasn't typical, and he significantly improved. So in conclusion, be interested in the patient. Be curious, utilize the system, figure out we're all here to figure out what is wrong with those patients. Luck is what happens when preparation meets opportunity. Be prepared. You're going to get lucky if you're prepared. And I want you to take the leap. Those are my kids. That's Andrew jumping off the slide, and that's Elena watching him jump off the slide. I want you to be Andrew. I don't want you to be Elena. I want you to be both because I love my kids. But be Andrew. Take that leap in your evaluation and your treatment of these patients. Don't be that bystander that's just looking back and saying, yeah, I think we're gonna do some prone stuff and this stuff, and because I think this is what it is. You've classified them, go after it. These are my references, and these are my other children. I now probably have 20,000 kids from somebody else's mom, but those are my 20,000 kids. Questions?
Feel free to either type into the chat or unmute yourself and ask. So while they're typing in, I do have a question. One of the things you mentioned on, I believe it was an articular dysfunction, you mentioned about making sure that the patient understood the expected prognosis, how long it would take to get better. What would you say the typical response time is for that?
I would say you'll notice a change 6 to 8 weeks. Like as you start to remodel, when you look at how you're going to remodel that tissue, you should look at 6 to 8 week timeline. Just as it took that long to come on, it's going to take that long to
awesome
to improve. And
how many hives do you have?
I have 2 now. One angry hive. They attacked me the other day. Man. Yes. That's what happens when you try and steal their honey.
What other questions do you guys have? I think the other thing that I got out of this, we need to make sure we're doing a good, thorough exam, making sure that there is no pathology that would preclude them from this, and that would be classified as other from this.
Yep.
So we need to make sure we rule that stuff out first, and that's part of a good history and physical exam. One question that was asked is with contractile dysfunction, range of motion is full, and then it's question mark both active and passive.
Yes.
Okay.
Yes.
And then the other question is, do you find a loss of active range of motion in the direction of the contractile dysfunction?
No, because the active and passive should be full.
Okay.
But they'll have pain with the active, possibly.
Okay, so it's not a loss of active range, it's pain.
Pain, correct. Does that answer the question? Who asked it?
Tanya, does that answer the question? Yes, I believe some patients may need to be asked, can they move further?
Correct. That is correct. So again, you're going to get that pain because you're loading if the active motion loads that tendon enough. And I think that's the clarification. If the active movement is enough load on the tendon to create the pain, that's something you may not get a pain response with just active motion. The bigger one is when you add load from a resistive test standpoint. So is the active range of motion going to provide enough load to produce the pain? That's really the question. If it's fear avoidance, that's a whole nother story.
Well, if anybody else has any other questions, please feel free to reach out to Dr. Bays. Email or other ways of contact would be awesome. And make sure that after this, you sign into EADS and make sure you complete your quiz and your course evaluation so that you get CE credit for this and CME credit for this. Thank you very much, and we'll see you next month.